Hello guys. Many questions were circulating for like couple of days on deep overbites, their etiology, then what are the clinical features, what are the different treatment modalities, and what would be the long-term stability after correction of deep overbites, and what are the factors we should keep in mind for the better long-term stability pre-treatment. Well, I could have given the answers just like that, but I thought that I should make this video so that your concepts should be clear about this problem, this type of malocclusion. So let's start now. Overbite is the vertical overlap of the incisors. Horizontal overlap is overjet. So this vertical overlap, it is called overbite. Well, in the normal occlusion, the lower incisal edges, they contact the lingual surface of the upper incisors just close to the cingulum. So we can say that the overbite is about 1 to 2 millimeter, or in some of the books it says that it is covering almost incisal third of the lower incisors. The upper incisors are covering incisal third of the lower incisors, or just little over 30% of the incisors. That is from Wolffel's Dental Anatomy, 9th enhanced edition. The opposite, when the teeth are not overlapping and there is a gap between the upper and lower teeth, we call it an open bite. And when it is present in the anterior region, we call it an anterior open bite. Well, this vertical separation of the incisors, that is measured to quantify the severity of the open bite. Overbite is described in terms of its depth and incisal contact. Overbite could be normal. It could be reduced or decreased when the overlap is not sufficient. Or it could be deep or increased when there is a lot of overlap, or the overlap is more than normal, more than 33% or 30%. It could be complete to dentition, or it could be hitting on the platal mucosa, or it could be incomplete overbite. Well, deep overbite most commonly present in class 2 malocclusions. The lower teeth might bite into the palate instead of onto the upper teeth, which is also known as traumatic bite or impinging bite, like this over here in this case. The lower incisors are hitting the palatal mucosa, or in some cases, upper incisors would be hitting the gingivae of the lower incisors and traumatizing that area. In class 2 div 2 malocclusions, the deep overbite is often the result of retroclination of the incisor teeth. Now keep in mind, the question could be asked in board exams about this, that why this deep overbite is more prevalent in class 2 div 2 cases. There will be many options, and our answer will be due to the retroclination of the incisor teeth. Etiology of this increased overbite. Patients who have excessive overbite, usually they have posterior teeth which are infra-erupted, or it could be over eruption of the anterior teeth, usually mandibular incisors. Well, anterior teeth generally erupt until they make a contact either with the opposing anterior teeth on their lingual surfaces, or they reach and start hitting the palatal mucosa, or maybe they are touching the resting tongue. Well, this increased overbite or deep overbite, it could be skeletal or it could be dental. How to differentiate between the two? Usually question in the board exams come on that aspect as well. That how you will differentiate between the dental origin deep overbite or the skeletal origin deep overbite. Well, in dental origin deep overbite, the curve of Spee will be accentuated. Whereas in skeletal origin deep overbite, the curve of Spee will be relatively flattened. Remember this thing. Well, other features are also there, like in the skeletal anterior deep overbite, there will be forward rotation of the mandible in the direction of mouth closing is due to increased posterior vertical facial growth compared with anterior vertical facial growth. There are 7 structural signs which were described by Jog found on a lateral cephalometric radiograph which may give an indication to the pattern of mandibular growth. The signs evident in forward growth rotators which can give rise to an anterior deep overbite. Well, what are those 7 structural signs? Forward inclination of the condylar head, number 1. Forward inclination of the condylar overhead. Number 2, if you will look at the lateral ceph, you will see an increased curvature of the inferior alveolar canal. Then third point will be, if you know that as the person starts growing, there is an antigonial notch over here which develops, and in these patients there is absence of the antigonial notch. It will be, the lower border will be quite flattened. There will be forward inclination of the mental symphysis like this, and then increased interincisal angle, obtuse interincisal angle. Then increased intermolar and interpremolar angle, and a reduced lower anterior facial height. Anterior deep bite may occur in the primary dentition. It is often associated with a short anterior lower face height, reduced mandibular plane angle, and a square gonial angles on both the sides. At this age, it is primarily skeletal in nature, and it should not be treated in the primary dentition because there is a chance of recurrence. Therefore, at this stage, we will just keep the patient under observation. When they will be just about to reach their growth spurt, prepubertal growth spurt, then we start treatment. We can use the myofunctional appliances very easily at that time. So in the early permanent dentition, a deep overbite may need to be reduced if causing trauma to the soft tissue, palatal to the maxillary incisors, or labial to the mandibular incisors. I have shown you the pictures. These are the indications in early permanent dentition for the treatment. Patients with a deep overbite causing palatal or gingival trauma, they fall in the treatment need category of IOTN, the index of orthodontic treatment need 4F. IOTN 4F. Deep overbite is often associated with an increased overjet during orthodontic treatment. An increased overjet often cannot be orthodontically corrected until the overbite has been reduced. Again, important point. Question could be asked on that. Again, I am repeating it. Deep overbite is often associated with an increased overjet. During orthodontic treatment, when this situation is present, an increased overjet often cannot be orthodontically corrected until the overbite has been reduced. So we have to reduce the overbite and then we have to correct the overjet for better retention. Correction of the deep overbite. Well, there are three ways to correct the anterior overbite. Number one is just absolute intrusion of the upper and lower incisors, moving their root apices closer to the nose and lower border of the mandible respectively. We are not letting the molars extrude, or there will be relative intrusion, means the incisors are being intruded, whereas reciprocally the molars are being extruded relatively. But it should be accomplished during growth. Then the extrusion of the posterior teeth, which would rotate the mandible downward and backward. And again, this is being accomplished when the person is growing, when the child is growing. If there is no growth, mandible will rotate downward. Now let's see the different treatment modalities for correction of deep overbite. The first and the most commonly used appliance is a removable appliance, which we call anterior bite plane. So what it does, the acrylic in the anterior segment, it let the lower incisors touch the acrylic quite prematurely. Hence, there will be a gap between the posterior teeth. And posterior teeth, they start over erupting, leveling the curve of Spee. Leveling the curve of Spee, like this. Well, myofunctional appliances are also being used, especially if there is a skeletal class 2 and patient comes to you before the prepubertal growth spurt. Then you can easily choose the appliance you trust the most. There are several appliances. We can have a separate lecture on myofunctional appliances because there are so many, just letting you know that you can use those for the correction of class 2 malocclusion, as well as if you see over here in this area, by selectively grinding the occlusal area so that the posterior teeth will start erupting and the curve of Spee is going to be leveled. So use of these functional appliances, it causes an increase in the lower anterior facial height. Well, you can also use the fixed appliances, and using the heavy stainless steel arch wires like O2O size, you level the occlusal plane by a combination of mainly extrusion of the posterior teeth and to a lesser extent intrusion of the anterior teeth. Well, the incorporation of the second molars early in the treatment means you will be bending the second molars early in the treatment with the molar tube on the bend. You will be able to level the arch. The molar tubes, they are placed slightly more occlusally, because if you will place those more occlusally, then the wire will intrude the molar. This causes extrusion of the first molar and premolars, but it will cause relative intrusion of the anteriors as well as relative intrusion of the second molar. We can see the arrow over here. It is intruding. Another treatment modality is use of the reverse curve of Spee wires. I have taken this picture from Journal of Clinical Orthodontics from their June issue 2020. Well, it is a common practice to use a reverse curve nickel titanium wire to correct a deep bite caused by a deep curve of Spee in the lower arch. It usually takes about 3 months to flatten the curve with a constant force of approximately 300 grams generated by the wire itself. Rickett's utility arch. It could be used in the upper arch, it could be used in the lower arch, it could be used in both the arches. It will be intruding the incisors and relatively extruding the first molars. But to reduce the extrusion of the molars, what we can do, we can use twin tubes. One for the main wire, the main arch wire, and the other one for this auxiliary or utility arch wire. This is known as Connecticut intrusion arch. And I have taken this again from the Journal of Clinical Orthodontics published in December 1998. This is the position before it is being engaged into the anterior teeth. Once you will engage it into the anterior segment, it tends to go back to its original position, will intrude the incisors and relatively extrude the molars, as well as some of the rotation of the molar is also going to be performed. Low pull headgears, they are used for, headgears are used for different purposes, like for the extraoral anchorage, for distalization of the molars, for complete en masse of the maxilla. Well, keep in mind that if you will be using upper, high pull headgear, then what is going to happen? The parietal headgear. What is going to happen? It will intrude the upper molars. And if you will be using the low pull headgear or cervical headgear, it will be extruding the molars. Here we can see before treatment and after treatment tracings, and we can see that upper molars have extruded a little bit more. Hence the deep overbite has been corrected and the lower face height is also increased. I have taken it from Profit. Well, again, I have taken this picture from the Journal of Clinical and Diagnostic Research published in July 2014, just to give you the idea about absolute vertical anchorage. Absolute anchorage is possible only in two ways. One is if you are using the temporary anchorage devices, or you are using the mini implants, which we call TADs or temporary anchorage devices. Or if the tooth is ankylosed. Which tooth? The one which you are using for anchorage purpose, if it is ankylosed. So these are the two only possible situations where we will get the absolute anchorage. Absolute anchorage means the anchorage is not moving at all. Otherwise, anchorage moves a little bit, no matter how much, but it moves a little bit. So you can use very effectively these mini implants for intrusion of the incisors in correction of anterior deep overbites. Very, very effective. Well, orthognathic surgery can also be done, especially if deep overbite is associated with a skeletal class 2, where bilateral sagittal split osteotomy is going to be done or BSSO is going to be done. Well, in that case, what is going to happen? There will be a 3-point contact. So where it would be? One, it is going to be at the incisor region and then bilaterally at the second molar region. It will give some space occlusally for the premolars and first molar. They will erupt, they will be leveled, and they will level the curve of Spee. Well, keep in mind, the lower arch can be leveled even using the post-surgical orthodontics as well. It is important to note that the additional arch hand length would be required for post-surgical leveling. It could be obtained by either maintaining some space in the lower arch before surgery or by the proclination of the lower incisors after surgery. Yes, segmental surgery is also possible. You can go for the subapical osteotomy or you can go for mandibulotomy as well, depending upon what you want to achieve. So, and it is only considered in adult patients where leveling the curve of Spee by orthodontics is not possible. If the lower anterior face height is to be maintained, a subapical osteotomy is undertaken to set down the lower labial segment. And if the face height is to be increased, a segmental osteotomy including the lower border is undertaken, which we call mandibulotomy, this one. An anterior subapical maxillary segmental osteotomy, same type of osteotomy in the maxilla, in the incisor region, it can also be done to reposition the upper labial segment, particularly when there will be anterior vertical maxillary access. So when we are going for the maxillary intrusion and when we are going for the mandibular intrusion, we will discuss it in a bit. Pre-treatment considerations. What we need to keep in mind before we will start the treatment, before we start correction of the deep overbite. First of all, age. Age is very important. Patients with deep traumatic overbite are best treated during the growth phase. At that time, the correction is relatively straightforward and is usually before any long-term periodontal damage occurs. Growth modification using various functional appliances with capping of the mandibular incisors or a simple upper removable appliance with an anterior bite plane may be used during the growth spurt. After growth is completed, any extrusion of the buccal segments tends to be unstable due to stretching of the pterygomasseteric sling. In these cases, true intrusion of the incisor teeth is required. Well, in some cases, a combined orthodontic and orthognathic surgical approach would be required. Smile line consideration in deep bite correction. Maxillary incisors in relation to the upper lip at rest should be about 2 to 4 millimeter visibility. That's how we check the visibility of the incisors at rest. In patients who have reduced incisor exposure at rest, we need to intrude the mandibular incisors. Otherwise, patient is going to have a look like they are quite aged people. In patients with increased gingival exposure, which we also call the gummy smile, it is better to intrude the maxillary incisors. Now, after the treatment, how we can say that our treatment is stable in the long term? Long-term stability after deep bite correction, well, there are several factors which play very vital role. The good interincisal angle, correct mandibular incisor edge centroid relationship. Then avoid the change in the intermaxillary height if the person is not growing, if they are beyond the prepubertal growth spurt. Proclination of the lower labial segment in class 2 cases. Are you going to do that? Keep that thing in mind, that how you are going to tackle for the long-term stability if you have proclined the lower labial segment. And then if a person is having vertical facial growth, till when we will be giving them long-term retainers, etc., etc. First of all, the interincisal angle. There is a very nice article published in Taiwanese Journal of Orthodontics in 2021. And according to that, the long-lasting challenge of deep overbite correction is the stability of tooth movements. The interincisal angle might play a critical role in the stability of deep overbite correction. Berg et al. Suggested that the interincisal angle should be reduced to less than 140 degree. Average is 135 degree. Lower interincisal angle is a better choice for long-term stability. Riddle et al. Suggested that a large interincisal angle at the end of treatment was associated with the relapse of deep overbite. Then edge and centroid relationship. The most important factor in long-term stability after overbite correction is the relationship between the mandibular incisal edge and the maxillary incisor root centroid. First of all, what is this? Which edge? Edge, it is the tip of the crown, most prominent lower incisor. And then what is the centroid? In this edge centroid relationship, the midpoint on the root axis of most prominent upper incisor. This is the centroid. And there should be just 2 millimeter distance. For stable occlusion, the lower incisor edge should 2 millimeter in front of the centroid of upper incisor. Again, an important point. Question could come in your board exam about it. What would be the relationship? But when the lower incisor centroid is behind the upper incisor centroid, it should be corrected to get stable occlusion. And how we can do that? This is achieved either by retraction of the maxillary incisor root from here to here. Retraction of the maxillary incisor root from here to here. So centroid using the fixed appliances with plateal root top, or by proclination of the mandibular incisor, depending upon the clinical situation. Then comes intermaxillary height. Avoid change in the intermaxillary height in patients where growth is already completed. They are now beyond the prepubertal growth spurt. The extrusion of molars in these patients is unstable, as the muscular forces from the pterygomasseteric sling will cause relapse of the molar extrusion if the posterior vertical face height has not accommodated their extrusion. If you have accomplished the treatment using lower incisor proclination, then kind of long-term, or which we call the permanent retainers, should be placed. Vertical growth pattern. In patients having vertical facial growth pattern, it continues into the late teenage years. The pattern of facial growth does not tend to change after treatment. It is necessary to place an anterior bite plane on the maxillary removable retainer after completing the active orthodontic treatment. Instruct the patient that it should be worn on a part-time basis to maintain the corrected overbite until the dentist or orthodontist, they instruct that, okay, now stop using it. Now, the final words or conclusion. In correction of an anterior deep overbite, the clinician's approach towards diagnosis should be thorough and specific for the needs of that particular patient. It will help in reaching the correct treatment goal. Patient's age, pattern of their facial growth, and the type of malocclusion, whether it is just class 1 malocclusion or it is class 1 div 1 or class 2 div 2 or whatever situation it is. These are the factors which play very vital role in the treatment outcomes. So you have to keep in mind all these points before you start treating a case of deep overbite. It is not a very simple case. It will be coming with a lot of other complications with it. So over here we are done with this not very long, but you can say a very brief and concise lecture on this topic. Hopefully you have enjoyed it. So let me know if you want lectures like this in future. I will be definitely